Hello, my name is Leslie Rattan, and I am happy to welcome you back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. For those of you that have been here before, you'll know that we have an ongoing webinar series running every other week on Tuesday evenings. And this consists, we go from 6 to 7, and we have expert speakers typically speaking for the first half of the session, and then we open it up to your questions for the second half. So if you do have a question tonight for our speaker, you'll see, if you look at the bottom of your screen, you'll see a Q&A. Please enter your questions there. If you're having any technical difficulties, you'll also see a chat box at the bottom. So just enter any issues that you might be having, and Kristine can give you a hand there. Just also, just so you know, if you have missed a past webinar that you would like to watch, you just need to go to the Canadian Concussion Center's website, and all of our previous talks have been archived there. So you're able to watch those, and many as well have the associated presentation that you can actually look at as well. Before we go any further, we're just going to run and thank you, Kristine. He just put a link into the chat, and also has just posted a poll. We just like to get a quick sense of who we have in our audience each time. So I will close that. So this evening, I'm really excited to introduce Dr. Kristine Dalton. This is actually a brand new talk in our webinar series, and she's going to be talking about optometry post-concussion. And Dr. Dalton is an associate professor at the School of Optometry and Vision Science, an optometrist, and a leader in the field of sports vision and concussion rehabilitation. After establishing and directing the Vision and Motor Performance Lab in 2013, Kristine went on to found the Sports Vision Clinic at the University of Waterloo in 2014. And under her leadership, the Sports Vision Clinic expanded its services to include the Brain Injury Clinic in 2019. In her clinical work, Kristine provides performance vision enhancement and vision rehabilitation services for athletes and individuals with traumatic brain injury. Kristine has published over 20 papers and 80 conference presentations and supervised over 40 undergraduate and graduate students. Her research interests include sports performance, traumatic brain injury rehabilitation in able-bodied and parasport, and Paralympic classification for athletes with vision impairment. Her work is helping to develop one of the first sports-specific classification systems for para-athletes with vision impairment, as well as national and international guidelines on concussion management for para-athletes and in optometric clinical practice. Kristine is a member of the Concussion and Parasport Group, a fellow of the American Academy of Optometry, a fellow of the British Contact Lens Association, and a recipient of the Excellence in Science Teaching Award 2018 at the University of Waterloo. So I'm really pleased to welcome Dr. Dalton, and I will turn it over to her now.
Thank you for that kind introduction, Leslie, and thank you for the opportunity to be here with you all tonight and share a little bit of my background and my experience with concussion, and hopes that it helps some of you. I have no financial disclosures related to the talk tonight. So as we start, just to orientate us as we get started and settled in, when we're thinking about the visual system, we want to think about there's various components. So we have our optical system being the eye, which is really what collects information from the world around us. That feeds into our brain, where we consider that to be more of our perceptual system, where we interpret the visual information coming from the eye. But the brain also then feeds back to guide the eye and guide its eye movements, direct where we're looking, and help the two eyes work together and function properly so that we can see and navigate the world around us. So as I was saying, with the visual system, we have the optical system, the eye, and then the brain itself. And this is really the system I'll speak to, well, a lot about what we'll speak to today when we talk about the role of optometry in post-concussion care. In addition to the visual system, though, the eye also feeds into what's known as our vestibular system, which is a combination of the semicircular canals in the ear and then feedback and information from the eye that helps us control our balance and our awareness of our positions in space. And this system can also be impacted by concussion as well. So when we think about concussion and the common symptoms associated with concussion, right, there's a wide number of them here on this screen that are displayed here. And there's quite an array, a diversity of symptoms that are associated with concussion. However, interestingly, a large number of these symptoms actually overlap with symptoms associated with simple eye problems. So there's also a number of things like headache, fatigue, trouble focusing, reduced reaction times, poor concentration. Sometimes those are just symptoms that we experience as optometrists, or we hear patients report as optometrists that are associated with not with concussion, but it's associated with vision disorders as well. So when we hear these in an optometry office, the challenge is, is this related just to an eye problem, or is there something else going on here with the concussion? And is there some sort of association between the two? When we start looking through the literature, it's interesting to see that up to 90% of patients who experience concussion, be them adults or adolescents, at some point in their injury experience will have some sort of vision symptoms. That doesn't mean that they necessarily have vision problems, but they will experience some type of vision-related symptom during their injury recovery period. And interestingly, more recent research in adolescents has shown that the presence of a vision or vestibular deficit fairly early on following an injury can actually be predictive of prolonged concussion recovery. That doesn't mean that everyone with a vision issue or vision symptoms will have a prolonged recovery, but if there are actual vision deficits present along with those vision symptoms, it suggests that those individuals may be at higher risk of developing persisting concussion symptoms. So when we think about concussion or vision problems after concussion, some of the common problems include things like headaches, focusing issues, difficulty reading, concentration difficulties. And other common ones we'll hear about include things like light sensitivity, motion sensitivity, or difficulty tracking or pain with eye movements. We also will hear about the vestibular-driven symptoms that impact things like balance and dizziness. Sometimes we can hear other complaints as well, things like double vision or loss of visual field, perhaps changes to pupil sizes or issues with dark adaptation, but those are fewer and further between. When it comes to concussion management and optometry, we aren't really involved and shouldn't really be involved in the acute stage of the injury. In those first couple of weeks after injury, that's not really where we have a role to play, I don't think, at least not in this point in time. More commonly, we're involved in in the care of patients who have persisting post-concussion symptoms and involved in the management of those patients with those symptoms. So it's patients who don't get better, patients who have prolonged recovery and who are now being referred out to multidisciplinary care teams. It's those patients that we as optometrists are working to help and support. Interestingly, when it comes to optometry as a profession and our care with concussion, we're still fairly new in our involvement as a profession with post-concussion care, and we're still learning as we move along. And so there is not yet a standard, specific, defined protocol for concussion assessment by an optometrist. However, when you're thinking about these assessments or you're looking for an assessment of your vision following concussion, your assessment should include at least a couple of pieces. One of those being a full eye exam, including careful refraction or checking of your glasses prescription, and a dilated ocular health assessment to look at the integrity of the eye itself to make sure there's been no damage to the eye in the head injury that triggered the concussion. Following that, there should also be an assessment of how your eyes work together, or a visual function assessment, which includes assessments of things like accommodation or focusing of your visual system, convergence, which is the ability to turn the eyes in to look at something up close, and also your eye movements. In addition to those two pieces, anyone working with patients after concussion, including optometry, needs to pay attention to non-vision-based problems as well, and pay attention for these in case additional referrals for care need to be made. When we then think about following our assessment, we think about how those vision deficits might be managed or how vision issues should be managed post-concussion. The first and foremost step is actually managing any sort of structural issues that are related to the integrity of the eye itself. Following that, we should address any refractive issues and issues of light sensitivity, which are related to your glasses prescription or your contact lens prescription, perhaps. And then after those two pieces, then the next step would be addressing any remaining visual function deficits if they persist, or any visual perception deficits if they're there. And the reason we move through this in this way is because structural abnormalities can impact both our refractive error and our visual function. And so we need to make sure those are addressed first as our foundation before we move forward. One of the reasons I speak about structural abnormalities is really important in the sense that our eyeballs are in our head, and it's typically often our heads that's impacted when we have a concussion. And it's important to remember that if our head's injured, sometimes the eye itself can be damaged or injured as well. It's estimated about 9% of all eye injuries requiring medical attention are sports related. And so when we start to think about eye injuries and concussion being sports related, commonly, not always, it's important to understand that there's no eye injuries as well. Interestingly, sports-related eye injuries can also affect pretty much any structure of the eye, right from the eyelids all the way back to the nerve as it runs to the brain. And so that's why that dilated health exam is really important to conduct up front, because we need to make sure that there is no obvious damage to the structure of the eye itself. From there, the next step is really paying attention to that refractive error or glasses or spectacle prescription. And we have some preliminary research in this area that's starting to show that there are deficits in the accommodation system in patients following concussion that can affect their glasses prescriptions. The accommodation system is a system that allows us to focus our vision, so it engages when we look at something up close to keep that near text clear, and it relaxes when we look at something in the distance. It's also an accommodation system that starts to work less well as we get older. That's when we need reading glasses when we hit our mid-40s. It's because the accommodation system is no longer working as well as it used to when we were younger. And it's that accommodation system that the reading glasses are starting to help take over the work for. But when that accommodation system is functioning, right, it functions to some capacity well into our 60s, not nearly as well in our late 50s, early 60s as it does when we're in our teens. However, if it's functioning, right, those muscles that control that system could spasm and cramp up, and that can actually sometimes cause a myopic shift in prescriptions or a nearsighted shift in people's vision, making their distance vision blurry. And that can be up to 1 to 2 diopters, which is a fairly substantial amount of nearsightedness to come as a result of the muscle spasms. However, alternatively, some patients find that post-concussion, instead of getting that cramping of those accommodation muscles, that system doesn't seem to function as efficiently as it did pre-injury. And those patients can sometimes benefit from actually having a hyperopic or a farsighted prescription to do some of the work for the accommodation system for them. And it's been shown that correction of small prescriptions, particularly those small hyperopic prescriptions in patients who are long-sighted initially, can actually start to improve patient symptoms. And it's thought to be related to deficits in this accommodation system and its function, which we can modify by correcting refractive error accurately and efficiently. So it's really important before we move into any sort of vision therapy or vision rehabilitation to ensure that you actually have, as a patient or a person suffering concussion, has an accurate spectacle correction, as that in and of itself can start to help improve some of your symptoms initially. Along with that spectacle prescription, it's really important to think about our light sensitivity. Sometimes even simple things like uncorrected prescription can contribute to light sensitivity. So that's one piece we need to ensure is in place. But in addition to correcting your glasses for patients who are light sensitive, we can think about introducing something which is called a tint or a filter. These are typically colored lenses, and they come from a wide variety of colors, but they essentially cut some of the light, reduce the amount of light entering the eye, and are designed to try and improve patient comfort. Research on tints is still a little bit limited. It is still limited, certainly, in terms of which color is best for people post-concussion, or how effective are they, and then should they be worn full-time or should they be worn as needed. And there's still mixed evidence there and research that really needs to be done. But from a clinical perspective, they can certainly provide profound relief for some patients. And so when you're thinking about tint trials, at least when I'm doing them in clinic, and when you're thinking about exploring a tint option in patient care, we typically tend to show patients all of the options available to them, the variety of colors, some shown here, including blues and plums and rose-colored lenses, as well as sometimes some yellows or neutral grays or various colors that way, and seeing if any of those colors actually improve patient symptoms and symptomatic relief in a bright room. If they do, then we have options to prescribe those tints either for full-time or part-time wear, depending on how that patient feels they need them at that time. Once we've established and understand what the refractive area is and have corrected it appropriately, and we've decided on whether or not we're prescribing a tint, then the next step is really about prescribing a pair of glasses. If there's a disorder of how the eyes are aligned, that's been maybe perhaps longstanding or pre-existing before the injury, we may use what's called a relieving prism to help the eyes line up better if there's a persistent binocular vision defect, but that is relatively rare. Primarily, we're looking at changing the glasses and then prescribing a tint if need be. Sometimes patients want those tints full time and they can be ground into the glasses and prescribed that way. But alternatively, we can prescribe them on an as needed use so patients can gradually increase their exposure. And the simplest way to do that is actually to have a custom clip-on made for a pair of glasses that has the tint in the clip and the prescription in the clear glasses, so you can put the clip on as and when you need it, take it off when you don't. Clinically, once you have your refractive correction, any change you make in your glasses prescription can take time to get used to. Anyone who's put on a new pair of glasses may well be familiar with that feeling. And sometimes, even post-concussion, even without a concussion, but certainly post-concussion, it can take 3 to 4 weeks for your brain really to get used to wearing that new prescription. And so from an optometry perspective, we want that your brain to adapt to that prescription and give you time to get used to that prescription. So I will typically ask patients to update their glasses and then wear them for 3 to 4 weeks before we make any other further changes. Once they come back, having worn those glasses for 3 to 4 weeks, we'll reassess their visual function and see if any other changes, such as any other deficits, are still present and whether there's a need for vision therapy or not. So when I speak of vision therapy or vision rehabilitation and those deficits that might lead to that, we're thinking about some of these more common deficits that are associated with the vision system following a concussion. One set of those deficits I've spoken about a little bit already, which is the accommodation system or the focusing system that can have deficits in it. We also have another deficit called convergence insufficiency, which is commonly associated with concussion. And convergence is the ability for us to turn our eyes in as we're looking at something that comes close to us. So when objects come closer to us, we turn our eyes in to keep the sweet spot of our vision on what we're looking at. And as things are out in the distance, we turn our eyes out to look at them a little bit. And often it's an inability to turn the eyes in enough to see comfortably up close that is commonly associated with concussion. In addition to that, the literature has also reported in some instances disruptions in our eye movements, particularly our saccadic eye movements, which are quick eye movements that we'll make when we look between two different objects. To give you an idea of what those might feel like as a patient experiencing these deficits, right? This is an image. It's meant to be blurry. It's intentionally blurry. That's not your screen's resolution. But this is what it might be like to read if you have an accommodation deficit, meaning that you can't just get the text quite clear enough to be easy and comfortable to read. And you could imagine if you were trying to read or go to school or work through this, that all of a sudden, all that effort to try and see clearly, it might also make it harder or exhausting to try and concentrate on what you're doing or pay attention to what you're doing, and can compound aggravating other symptoms and fatigue. Right. Convergence insufficiency is another deficit that affects our near work, can make that quite uncomfortable. Well, instead of making things blurry, it often makes things double, like shown here in this image, where you get a ghosting or almost a doubling of the text you're trying to read. That again makes it quite challenging to concentrate on, focus on, and navigate as you're moving through, that life or that school activity. In addition to the convergence and accommodation deficits, there are some eye movement deficits that we'll see clinically in patients following concussion. The first of those deficits is sometimes that we'll see is in our fixational movements, eye movements, which are eye movements where we're looking at something nice and steady. So it's a steady gaze. And when we're looking at something steady under normal conditions, the eye should be quite still, right? We shouldn't see it. It's a bit of an exaggeration for demonstration purposes, but the eye should be quite still and steady when you're looking at a target. The next few animations will include a bit of motion, just to warn anybody who might be motion sensitive in the audience. So the motion will hopefully help explain these deficits to other individuals. So in cases of fixation deficits, what we start to see is that instead of the eye gaze, the gaze position as represented by this gray dot being nice and stable, we start to see it sort of shake, move around, and that the patients aren't able to maintain a nice and steady, smooth fixation on things. Pursuits are tracking eye movements. And so under normal conditions, these are the eye movements we'll use to follow something that's moving at a reasonable speed across our visual field. And under normal conditions, when our eyes are tracking an object, like this eye tracking this, the gaze tracking this arrow here, the eyes will actually follow that object in a fairly smooth and accurate way. But following concussion, we can actually see disruptions in that where the eyes are not tracking accurately and they either overshoot or undershoot relative to the object they're looking at. And so someone with pursuit deficits might have eye movements like this, where they move but don't stay on top of the object well and feel like they're always lagging behind to try and catch up with it. C.E.T.S, as I alluded to earlier, are quick eye movements that jump between two separate targets. And under normal conditions, they're actually really quite fast and quite accurate. So if the eyes are looking where the gray dot is and want to look over to the X, we make a C.E.T. It's usually a really quick, rapid eye movement to the target we're looking at that lands on the target accurately and comes back to and moves from there. It may come back to its original position. But following concussion, those can also be disrupted and they can be too large or too small. They can also be slower than normal. And so we can see that sometimes we see people overshoot or undershoot and then have to make a second eye movement to be able to get back to the target they're looking at accurately. And when all of these types, any of these types of deficits or all of these types of deficits are present in patients, it can be really uncomfortable and difficult for patients to navigate everyday life because so much of what most of us do relies on visual information. Whether that be reading our phones or working on a computer or driving or even walking down the aisle of the grocery store, so much of what we interact with the world with depends on our visual input. And so disruptions in how that information is collected or how the eyes are working together to collect that information cause a lot of symptoms. So when we think about vision therapy then post-concussion, vision therapy is different than vestibular therapy. Vestibular therapy is typically provided by physiotherapists who have a specialization in vestibular rehabilitation, and that can be really important for symptoms of dizziness, sometimes nausea as well, but particularly dizziness, vestibular therapy can be really beneficial. Vision therapy is really focused on working on how the two eyes are working together to collect information efficiently from your environment. And it's typically provided by optometrists with some sort of specialized training or experience. And it's been found to benefit some patients with persistent concussion symptoms. It's not guaranteed to benefit everyone, and there's still a lot of research that we need to do in this field, but at least some of the early research seems to suggest that vision therapy, when it's administered, seems to be the most effective for those accommodation deficits, convergence insufficiency, and oculomotor deficits. And it can also contribute to an improvement in persistent post-concussion symptoms in some patients. Clinically, I've seen this as my experience, but I've also seen clinically that it doesn't necessarily work for everybody. Right? And so it's a balance with trying to understand what your approach is to vision therapy and what you're looking for as you move into it. When we think about vision therapy for these patients, I think it can be considered in patients who have persistent post-concussion symptoms with some visual dysfunction. Right? So that's a visual function dysfunction that persists after getting your glasses corrected, making sure the eye is nice and healthy and there's no damage to the eye. If there are functional deficits still remaining, then vision therapy can be a good option to explore to try and see if we can rehabilitate or rebuild those visual functions to help your visual system work more efficiently. Typically, when we think about vision therapy or vision rehabilitation, whether it be for concussion or not, it's typically a collection of exercises or visual exercises that can be done either in office under supervision of an optometrist or a certified vision therapist, or at home on your own. And both in office and at home therapy can be effective for patients. When I'm explaining to my students, I often will say vision therapy to me feels like a strength and conditioning program, but for the visual system. And in-office therapy is kind of like going to the gym and working one-on-one with a personal trainer. Right? You get lots of attention, you're working one-on-one on equipment you can't really buy for home. And then that will be supplemented usually with some sort of exercises or work to do at home. At home therapy alternative is still going to the gym, but you get a custom program from your trainer, and then you take that program home and you buy some equipment and you do the workouts at home. Both programs can be effective, but the one that's going to be the most effective for a patient is the one they actually do. And so I use both models quite interchangeably, depending on what my patient's needs and demands are. And I think that flexibility in delivery can be really important for patients post-concussion as they're balancing all of their other appointments and work and school demands as well. So when we think about establishing a vision therapy routine or what we're trying to do with vision therapy, first and foremost, we're trying to get the eyes to work well individually. So monocularly first, working on the accommodation system to make sure we can keep things clearly, and also the eye movements or the oculomotor control system to make sure the eyes are functioning well together, or that their eye movements fundamentally are clear. As we start to get that monocular function working well, we can incorporate binocular tasks or tasks that require both eyes to coordinate together. And that includes training for things like convergence insufficiency or divergence, which is the opposite, the ability for the eyes to turn out. It can also include sometimes anti-suppression training, where we're retraining the eyes to pay attention to or the brain to pay attention from both eyes at the same time, rather than one eye at a time or the other. In addition, as we're layering these in and we start to build up the program as people's skills progress, visual skills progress, we can incorporate and lay in visual spatial awareness training, perhaps some vestibular work, looking at peripheral awareness, motor coordination, vision motion tolerance for things with patients with motion sensitivity. And as if we're working particularly with an athlete or someone going back to a demanding job, we can start to layer in vision skills that are more complicated and replicate what they might do on the field of play or in the sport. If we are doing vestibular training, it's really important that we have, I like to have a physiotherapist involved in that program, because I think that they have a lot more expertise in some of the impacts of the vestibular system than I do. And so I would much rather work with that patient's care team, particularly when it comes to systems that are not in my, domain of everyday expertise. So I really like to work with physios to kind of collaborate and work together on these two systems. When we think about some of the other things that you'll hear, other terms you'll hear when you hear about vision therapy, things like binasal occlusion, or yoked prisms for midline shift post-concussion, or things like syntonics or ocular exposure therapy. These are other methods of trying to modify the visual system to try and improve its function or to reduce patient symptoms following post-concussion. While they seem to have some effect in some patients, and there seem to be some positive case results, there's even less literature out there supporting these methods of vision therapy than the literature that's out there supporting some of the accommodation and convergence training. And so really the evidence supporting these interventions is really quite limited, and we need a lot more research to understand if these are effective and when they're effective for patients. And so for me, at least as a vision therapy provider, these are not my first choice options because we have the least evidence supporting them, right? I'd like to work with some of the more traditional methods first, working in these spaces we have more evidence like the accommodation convergence training. And then if we need to, if that's not effective, after a careful discussion with my patients, we can think about adding in some of these other types of modalities should we need to. One of the challenges we have with vision therapy, and my patients ask me it all the time, and my students ask me it too, and I don't have a great answer, is to say, how long do I need to be here? Or how long does vision therapy take post-concussion? And right now, we really don't have a good answer for that. There's research that's starting, it's early days, but we still are just starting to do research understanding the natural history of these vision disorders following concussion. They've never really been studied in depth. And so I'm part of a group that's working to try and understand them from kind of injury onset and then what happens over time to see, because we don't know, and it's hard to do research because we don't know what happens naturally, to tell vision therapy speeds up that natural course of recovery or not, right? So really, we don't know. When patients ask me that question, I say, I don't know how long your vision therapy will take. Typically, my experience in patients with concussion is vision therapy progresses slower than vision therapy might be in someone who has a binocular vision deficit, but without a concussion, right? And so with that in mind, I say probably on average, patients can spend, I don't know, maybe 6 to 9 months here, but it could be 3 months, it could be 2 months, it could be 2 years. There's really no set answer. There's no magic number of how much vision therapy you need to recover from a concussion. And with that in mind, what I say to my patients and the approach that I like to see people take, or I think is sensible to take, is we have that conversation early on and then speak with patients and work in small doses. So typically I will work in 4 to 5 sessions of in-office vision therapy, typically 5 sessions. And then I'll check your progress. So we'll measure your numbers again, check your progress and see if it makes sense to continue. It's the same idea with that at-home vision therapy. We might give you a program, have you work on it for 4 to 6 weeks, have you come back in, remeasure your numbers and see if it makes sense to continue. If it makes sense to continue, we can tweak your homework, make it harder, make it more challenging to help you continue to progress. Or maybe we've reached a point where you've made the progress you need and you can discontinue care at that point because you've accomplished your goals. But that frequent reassessment and monitoring allows us to make informed decisions with our patients of when it makes sense to continue care, or maybe when it makes sense to say, you know what, this is plateaued, it's not helping anymore, and I need to try something else and move on. Right? And so when we're having conversations about continuing vision therapy with patients, it really needs to be based on that reassessment data and how they're functioning, along with a conversation about the patient about how they would like to proceed and what else is on their plate at that point in time and whether or not it makes sense to continue with vision therapy for another short course of treatment. Just before we wrap up, I want to touch on one other population where I think optometrists can play a role post-concussion, and that is actually in athletes and individuals with vision impairment. So some of the early research in this space is starting to suggest that concussion incidence in parasport or sport for people with disabilities is comparable to incidence in able-bodied sport, and may actually be even higher in athletes who have a vision impairment, meaning they have low vision or blindness. What's challenging in this population is that many of our common signs of concussion, including things like blurriness and double vision, may be really normal for that patient because of their vision impairment, and a concussion may not, right? We may be reporting those concussion symptoms which were already normal and habitual for that patient. And so it can be more challenging sometimes to recognize the symptoms of concussion in these populations, particularly athletes with vision impairment. There's now a great resource out that's come out from the Concussion and Parasport group on their position paper about how you might assess and start to manage concussion in athletes with impairments, including vision impairment, but also physical impairments and intellectual impairments, because many of our traditional methods for assessment of concussion need to be modified or adjusted to consider the athlete's original impairment and the abilities they may or may not have. So there's a great resource. It's a freely available paper for those who are interested. And when we think about this population, particularly athletes with vision impairment, that optometric assessment by an optometrist can actually be really, really important, and probably even more important perhaps than it might be in someone who sees normally, right? Because that optometrist is going to help us identify what vision deficits are related to the concussion and which are related to the pre-existing visual condition. And it's really interesting to start to think about athletes with vision impairment. They may also require unique accommodations during the recovery due to the demands of navigating a visual world with limited or no vision, right? So as we think about how much our reliance on our vision helps us navigate the world, all of a sudden, if we're missing vision or we have a vision impairment, that can be more challenging, and accommodations for return to work or return to school may need to look quite different than they do for someone who's sighted. The Canadian Blind Sports Association has done some nice work in setting a starting place for this and have some really good concussion resources available to athletes and care providers, freely available on their website, about concussion assessment and also common accommodations that may be helpful for people with vision impairment returning to life after an injury. And so as I wrap up in summary here, I'd just like to say, I think that when we think about the role optometry might be able to help with, or the role of optometry in concussion care, it's really in those chronic patients with the persisting post-concussion symptoms. And optometrists can really help determine if the vision deficits are present, right? Whether they be structural deficits with dilation first, refractive deficits related to your glasses prescription, or after that, if there are still visual function deficits present, including deficits of accommodation, convergence, and eye movements. And then if there are those persistent deficits present, they can be treated, first of all, with updated glasses prescriptions, and then if necessary, additional vision therapy or vision rehabilitation exercises may be beneficial in some athletes. However, even as I provide this care clinically for people and we talk about it here as an option for people, we recognize, and I recognize, that we need a lot more research in this space, and we'll continue to need research in this space. And so with that lack of really strong, good clinical evidence, we also need to think about our management being patient-centered, right? We need to be upfront with patients, honest about what we're talking about, and say we're willing to try things, but equally, if it's not working, we can stop, right? And we can work in small doses and take steps that seem reasonable. And then as optometrists, we have a responsibility to work with that patient's care team to also ensure that they're getting the support they need and that we're helping the team facilitate the recovery to ensure that the best quality of life for the individual themselves. And so with that, I'd like to say thank you again for the opportunity to share a little bit of something I'm passionate about with you, and I'm happy to answer questions.
Okay, there we go. That's great. Thank you so much, Dr. Dalton. We have quite a number of questions, so let me just pull these up. So Heather is asking, and this is, you hear this a lot, what can you do to help with light sensitivity after brain injury? I am 4 years out now.
That's always a great question. I mean, from an optometry perspective, one of the things we talk about is things like tints and filters, learning to maybe turn down the brightness on your screen or your phone, or modifying your environment. But there's also some suggestion that potentially reintegration training may also help in some cases. So gradual re-exposure training perhaps can potentially help as well, working with your team that way. So both of those things are options, but certainly sometimes sadly, we don't have an answer. Sometimes things don't always get better either. And it's learning about how we adapt your environment and your life to create a functional space for you following that injury. So CE.T.S trials, screen modification will help, but they aren't necessarily a guaranteed fix, right? And it would be working with your healthcare team to try things you haven't yet.
Great, thank you. How do we find an optometrist who has expertise in this area?
I think one of the great places to start is within your current care team, right? So with your physios, your physicians, whoever you're working with currently for your concussion rehab, they are probably the best people in your communities to know which of the optometrists in the surrounding area are able to provide concussion care as well, and should know who's in the community or be able to reach out to the community and ask for referrals. If your care team doesn't know anyone, you could certainly speak to your own optometrist. Optometrists across Canada, we communicate, we have forums, and we can, if someone's looking for care or something that they don't provide, we can reach out and say who around here might be able to help this. And so there's lots of resources that way. The College of COVD of Canada, so College of Visual Development, also has a resource where people can search and look for people who provide vision therapy, but people who provide vision therapy don't necessarily provide concussion specific vision therapy. And so it's better to speak to someone in the community and ask for a referral or ask if they know someone in the area who can help you and facilitate care.
Great, thank you. Can severe dry eye be related to, do you see this post-concussion?
It's a great question. I have no research evidence to support it, but in my experience, I have seen patients who experience more symptoms of dry eye post-concussion than before. So I look at ocular surfaces when I do assessment, but I don't have any evidence to support that other than I've seen in other patients and reported it that way.
Okay. Laura Lee is asking, I read that people who have a lazy eye tend to be more likely to have difficulty recovering from concussion. And she says that she read this in a book written by Dr. Collins, and she's just wondering why that is.
That's a great question.
And how to address it, she said. Yeah.
That's a great question. It's not, I haven't seen any literature around that, but one of the challenges with science research is we tend to exclude people with lazy eyes initially as we try and understand what happens in a normal situation. What may be happening is that when there's a lazy eye, so typically that's associated with a condition called amblyopia, meaning that one eye, when we're young, didn't develop its pathway, the visual pathway to the brain to interpret the information didn't develop as well as it could have or should have because of maybe the eye was turned or it had an uncorrected prescription, so the brain wasn't getting the clearest information it needed to develop that pathway normally. But if there's a difference then, and in a lazy eye doesn't see as clearly as the non-lazy eye or the better sighted eye, that can sometimes make providing vision therapy more challenging, and training the two eyes to work together a little more challenging because we have to think about modifying targets for people and adapting sizes and techniques. And so it can make the provision of therapy more challenging in the first place, which may be why you're seeing that sort of delay in response.
Okay, great, thank you. We have someone asking, I've been doing vision therapy and I now have prism glasses. Is it recommended to wear them all the time?
That's unfortunately a question I can't totally answer because I don't know why you're wearing the prism glasses. Prisms can be prescribed for a number of different reasons. Some are meant to be worn full time, and some are meant to be worn sort of temporarily to help rebuild and within therapy. So you would need to, unfortunately, I can't do a better job of answering that one because they can be worn both ways. We need to know why you're wearing them.
Okay. I saw a neuro-optometrist for an assessment, and once she determined that I didn't need prisms, had no further vision recommendations. I still have headaches daily, largely triggered by screens. I wear progressive eyeglasses. What would your recommendation in terms of getting support with this be?
So that's a great question. Not everyone who does prisms does vision therapy, or maybe it's thinking about the last time you had your actual glasses prescription checked from those progressive lenses as well. So it might be looking for, either going back and seeing if there's any sort of exercise or anything that could supplement your vision care unrelated to that prism right? If prism wasn't necessary, maybe there are exercises you could do. It might be seeking a second opinion. It could also be as simple as getting your glasses adjusted so that you're seeing your computer screen clearly through the right position in your progressive edition lenses, and having just a bit of an assessment to make sure you're using your glasses properly for your computers as well. But there's a combination of factors there. If you're concerned or you want another opinion, you could certainly seek another one out in the community you're in, try and see if there's anything else you might be able to address.
Great, thank you. Joel is asking, how can it be determined definitively whether visual symptoms with dizziness or nausea are being caused by the vestibular system or the visual system?
It's a great question. I think the only really way we can determine that with definitiveness is probably to try and rule things out. So it's getting a full eye exam, making sure your glasses are up to date, the prescriptions are up to date, and going through that process to determine if there are visual deficits present or not. If there's not, then they're likely not contributing to the dizziness. And again, it's going through that vestibular assessment with the physiotherapist to see if there's anything in that space contributing to the dizziness, and then either saying yes there is, or ruling those out as you go through. But it's really a process of elimination that way.
Great, thank you. Anita is saying, I'm a physiatrist who works in a concussion clinic. Are there any resources or exercises that we can share with patients who can't afford formal vision therapy? I find cost to be a big barrier for some of these services, even though they may be beneficial.
Yeah. Cost is always challenging with vision therapy, and I think that's a really great question. When we think about vision therapy and exercises, and thinking about cost and accuracy for patients, if they have insurance coverage, sometimes for even routine care, sometimes just getting updated glasses can be a good place to start. And then there are some exercises, simple exercises that can sometimes be prescribed that are relatively inexpensive. So things that you can work on the focusing system with a few sheets of paper, and different types of exercises that way, depending on the population you work with. But the challenge, I think, when you're prescribing vision therapy exercises is first you want to make sure that there is no glasses deficit or refractive error issue first, right? And that's the piece. If we can roll that out and no glasses is accurate, then you want to know what kind of deficits you're working with, focusing or alignment, and then there are relatively inexpensive exercises that can be prescribed. And at least when I have a patient that can situation, and as a physiatrist, I'd suggest maybe you reach out to their optometrist and see if there's things you can do that help facilitate care for them. Sometimes I've had patients that only have insurance coverage for physiotherapy, and so rather than them coming to see me, I'll work with their physiotherapist team and help guide some of the vision exercises that physio is implementing as part of their vision care program, because the patient has coverage for physio, right? And so I have conversations with their team about how can we find another way to get this care on an individualized basis. I don't want to just list out a whole bunch of exercises because it's really hard. Not everybody needs the same thing. But working within their team and creatively to make sure the patient can get the care they need is certainly a priority for me. And that's where I would suggest you start is having those conversations on a case-by-case basis with their team and seeing how you can be creative about providing care.
Great, thank you. At what point in the post-concussion care would someone actually look for this kind of treatment?
That's a great question. I think as we're still, as optometry, learning that we can help in this field, and as the medical field still learning we can help, and everyone's learning about this vision piece, I think that it's not really, when we think about the role optometry has, it's not in the first 2 weeks, right? It's really if you move into those persisting symptoms, and then depending on your community and where you have access to care, you could certainly start. I have referrals coming in my community now where we do this work within 4 to 6 weeks. If we have patients that are struggling, right, I'll see those patients fairly early on in their care and work with them early on and help the doctors make return to play decisions and pieces like that, and support them with, vision systems back to normal or not. And this is where we're at. But also I have patients that are, 2, 3, 4 years out that are coming in because this is a piece that they didn't have in their community and they're finally learning about now. And I think that that's okay too. I mean, the earlier the better if you can get it, right? But I don't think if you've never had it looked at, it's probably worth looking into it if you can find the resources. And worst case scenario, you're going to find out there's no issues there, and that comes off your worry list. So it's one less thing to worry about overnight, right? And then you can focus on what you know is going on still.
Yeah, that's great. Caroline's asking, I work in a concussion clinic and it is not uncommon for a client to see an optometrist and be told that they need prism glasses and vision therapy. However, the same client may see a neuro-ophthalmologist and be told that their eyes are fine and don't need prism glasses. It's very confusing and frustrating, understandably. Any comment on that? Why that might occur?
Yeah, I understand your frustration and your confusion, and I can empathize with it. I think one of the reasons we're seeing that, and we're still seeing those discrepancies, is we just don't have all of the research we need yet, right, to have a collective, directed, uniform care, and that's still going to take time, right? I think that until we have solid research and foundations, there are going to be different opinions on how things can be managed. And that's really where then having a conversation with your individual patients and going, we've got these different approaches, what feels right to you to try next, right? And that's, that what makes sense based on your finances, your resources, the time you have, your other rehab demands. What's the next step that makes sense for you as we move forward? Because it's still, we don't have the, good best practice guideline that's heavily evidence-based to lean on to direct all that care, and which is a challenge and a huge limitation in this space. Unfortunately, I wish I had a better answer. But.
Yeah, no, that's a tough one. Just trying to, what are the most common mechanisms? Just so you know, I'm going to those in the audience. I had a comment about questions also being in the chat, so I'm kind of going back and forth. What are the most common mechanisms of post-concussion visual deficits?
So the things I see most commonly in clinic are certainly accommodation deficits, whether that accommodation system is sort of cramped up and isn't relaxing to allow focus to change, or it's just not working as well as it used to. So it doesn't have the strength or the endurance it might have normally had. I see deficits in the convergence and divergence systems, so our ability, particularly convergence, to turn the eyes in enough up close to keep things single and clear while we're reading. Eye movement deficits show up fairly frequently. And then sometimes what I'll see as well is almost, it's not a true suppression, but almost that the brain doesn't deal with information from both eyes together at the same time well. And so the brain sort of compensates, and I don't have good evidence for this or good mechanism, but it seems like the brain almost learns to filter or an eye or pay less attention to it. So we end up with sort of a stronger dominance in one eye, just to sort of cope with how it's navigating the world, right? Because sometimes it's easier to function with one eye than two, but that really doesn't help in the long run because we're so used to working with the two eyes, and so many of our visual tasks require two eyes. And so sometimes I find I'm working with patients to try and rebuild the brain's ability to use information from two eyes together, which sounds like what we would traditionally say is anti-suppression training, but it's not a true suppression, like where the brain's totally ignoring an eye, right? It's just sort of got this selective attention thing. And I don't have a great scientific experience or research to support that, and then I see it commonly in some patients.
Okay, great. I have struggled with post-concussion symptoms for 10 years as a result of a motor vehicle accident. I've done vision therapy and eye movement therapy, which has helped substantially. I'm now 44 years old, so I'm starting to struggle with clearly seeing near objects. I bought readers, 1.25, which made things much clearer, but I quickly begin to feel nauseous and a migraine can quickly follow. I feel these same symptoms when I use sunglasses. Do you have any advice for how to address these issues? What type of specialized training would I need to be aware of when choosing an optometrist to help me manage the usual age-related issues alongside the ongoing post-concussion issues?
That's a great question. That age thing and that lack of reading vision catches up with us all, unfortunately. I think when it comes to the, it sounds like you've had a great experience with vision therapy, and it certainly made some improvements for you. When it comes to things like reading glasses and sunglasses, there's a lot of variables in there. So whether those are really centered over your eyes or not, if they're the actual most accurate prescription for you or not, depending on the curvature of the lenses, can sometimes induce migraines or symptoms of nausea. And so there's a lot of optical components of those glasses and just how they're designed that can contribute to symptoms as well. And so I would, if you have a regular optometrist that you're comfortable with, that would be a starting place to see if there's anything you can do from a glasses perspective that would make you more comfortable in your lenses and in the designs of lenses you're wearing. And then from there, if that's optically not enough, as that aging, process progresses, and it's reconnecting perhaps with where you've done the vision therapy before, and seeing if there's anything else you can add on top of those optical corrections to help you move forward and through it.
Okay, thank you. What is the most effective evidence-based vision therapy approach or exercise for treating convergence insufficiency?
So some of the best convergence insufficiency is one of the vision deficits we have the most evidence from, and there's a group of trials called the convergence insufficiency treatment trials that did a lot of work and looking at effective vision therapy techniques. And I think that if I don't have their program memorized off the top of my head, but some of it is just repeatedly training the eyes to turn in and out and follow targets as they're moving towards the nose. But their protocols would be the best and supported by the most robust evidence in terms of vision therapy for convergence. And I think a lot of their manuscripts are available in open source journals and pieces like that. Your optometrist would certainly be aware of those trials or could help you track them down as well.
Great, thank you. Shelley is asking, thank you for the discussion of tinted lenses for light sensitivity. What therapies are available, however, for post-concussion chronic sensitivity, not to light in general, but to invisibly pulse light sources, such as computer screens, fluorescent lights, movie screens?
It's a great question. And the flickering of light that comes through screens is certainly a challenge and can be a challenge to navigate. I'm not sure. There are companies certainly working to design screens that don't flicker as much. They're complicated to design. And those they're not easily and cost effective and readily available, convenient at the same price point as many of our current screens are. And so we don't have a great alternative yet. I know there's research going on even with Dr. Tatter and the University Health Network looking at some different screens that are trying to eliminate that flicker problem. So if we can't replace the screen, then it's thinking about how do we navigate your experience with that screen to make it more comfortable. Does turning down the brightness modify that? Does adding a glare cover or glare protector on the screen dim the flicker enough that you can engage with the screen? Or is there a way we can work on patterning out your engagement and doing it in doses where you can tolerate but prevent that maximal exposure that increases symptoms? So maybe it's working in shorter time spans and then taking break to get a longer duration of care. But it's unfortunately, because we don't have a good technological device to substitute, it's figuring out how we interact with those screens and modifying that to navigate that, because we're still trying to solve that problem.
Great, thank you. This one is actually a comment. It's not a question, from Dr. Cobley. I hope I'm pronouncing that correctly. And she is saying, I'm 14 months post-concussion. I started vision therapy 9 months post-injury, and it has helped significantly. I'm 61 years old. I was able to pick up a book for pleasure last month for the first time since injury. Therapy is ongoing, mix of in-office and home intervention.
That's phenomenal to hear. Thank you for sharing.
Nice to hear.
It's
yeah.
really nice to hear. Yeah.
Yeah. After my concussion a few years ago, I had vestibular issues and also needed new, slightly stronger glasses. However, the new glasses initially made me very nauseous, something that had never happened before my concussion. I was fine after a few weeks, but I'm having the same issue again as I try on glasses in order to have a spare pair. This is again making me very nauseous. Any suggestions?
So adaptation to glasses can be really challenging for some patients, and that seems to be post-concussion that we're more sensitive to that adaptation. I notice I have patients that struggle through that adaptation period. So when you're thinking about getting your second pair of glasses, when you're thinking about having them designed, you may want them to try and match the curvature and the shape of the lenses in your existing pair, because that may help smooth some of the adaptation processes. But also sometimes it's just gradually exposing yourself and building up your wearing time and your tolerance to them, and being patient, because adaptation can often take 3 to 4 weeks, even in someone who's totally healthy with a brand new pair of glasses. And so when I speak with my patients and we're doing prescriptions, we'll say, maybe start with an hour wear a day on that new pair of glasses. At the end of your day, after school, after work, where, you know, you can go to bed after if you need to, right? Get all your busy work out of the way, start with a little bit of wear, and then try and gradually work up to full time over a weekend, maybe where you don't have the same sort of pressure or demands, and see if you can gradually increase your tolerance for those lenses. So gradual adaptation, exposure, and then trying to match your existing pair as much as possible optically could both help facilitate that transition.
Okay, great. Judy's asking, if a person has had persistent vision problems for 15 months post-concussion, is it too late to start vision
No,
therapy?
not at all. No, it's not too late to see if there's anything we can do.
Okay. In relation to the tinted lenses, is there typically a plan of weaning off of these lenses? If so, what does that look like?
That's a great question. So my preference for tints for a lot of patients is to do a clip-on or a second pair of glasses, so you can use them as you need to, and hopefully as your symptoms change and you recover, that you can try and use them less or become less reliant on them. So having that flexibility certainly is one way to go about doing that. And so it would be sort of, I guess, gradually increasing your exposure to lights without them in incremental doses would be sort of the kind of maybe way you could try and wean off of them, just as we're kind of trying to gradually rebuild skills. But I mean, sometimes, you know, I have patients that can't get off of them either, and that just means we wear the tint and we find a functional solution that works, right? But sort of trying to gradually increase light exposure or time spent without the tints, or environments that you don't wear the tints, can be a great way to start to wean off of them if you have that flexibility. But equally, if they are really important and they help you cope with life, you know, and that's how you function, that's okay too, right? If that light sensitivity is persistent and it's something we can't unfortunately get rid of, but the tints help you have a quality of life, you know, that's okay. That's great. I mean, we found a solution that helps you re-engage with life in some way. It's not a perfect solution, but it's certainly a lot better than nothing. Right?
For sure. And just kind of following on that, someone was saying
Yeah.
they'd never actually heard of the tint clip-ons. And they're just wondering, are these available broadly? I've been concerned about putting tints into glasses as they're very expensive progressives. And if they didn't work, would obviously be costly.
I think a lot of opticals do them. You just want to ask who there are some frames that are designed that maybe have a magnetic sunglasses on them already that can be the sunglass lens, and that magnetic clip-on sunglasses could be changed to the tint you need for your post-concussion. There's also companies, optical companies, that will do custom clip-ons and design them to match your frame. They're a little bit more expensive sometimes than just having the tint ground into the frame, but they give you a lot of flexibility and options that way. And so you can lots of opticians across the country will do them, and it's just asking those questions and if it's possible, or if they can look for a frame where a clip can be made or has an existing clip already.
Okay, great. Leslie is asking, I am being recommended for eye movement desensitization reprocessing training with a social worker. My prescription eyeglasses are up to date. My challenges are blurry vision with occasional double vision and fixation floaters. And she is wondering, is this type of training recommended?
So resensitization therapy can certainly be something we recommend, and gradual re-exposure to therapy, including visual motion therapy. And I haven't come across, at least in my community, social workers providing that care, but I also know that when it comes to vision therapy, lots of people are involved in helping, and because not all communities have an optometrist who can prescribe it either, right? And so it's hard to comment yes or no if it's recommended without a lot of details, but
I think what she may be referring to, and I don't have expertise in this, but they actually use this kind of training for when you have a history of trauma, for example. But I believe that you're moving I think there can be, so I'm picturing that, but I'm not entirely sure. So
I apologize. I'm not very familiar with that, so I wouldn't feel comfortable giving a recommendation.
Yeah. Sorry, I'm trying. Oh, we're right at time. Let's see. Let me ask one more question. In Ontario, is any of this covered? My insurance won't cover vision therapy, and I'm unable to work due to injury.
Unfortunately, not with OHIP. So concussion
Yeah,
vision care for
yeah.
concussion disorders is not covered through OHIP. Sometimes we have luck getting coverage through private insurers, but even that is still inconsistent and unpredictable. Some clinics offer charitable care programs sometimes that people can apply to, or alternative rates of funding that you might be able to apply for. So if it is, financial constraints and being off work, seeking, asking in your clinics if there's a charitable care feature or something like that, that might be a program separate to that you could apply for. That might be another alternative. But unfortunately, right now, the vision therapy is not covered by OHIP, and neither are the concussion assessments.
Yeah. Okay. Thank you so much. My apologies. I know we have more questions, but we are at time. I just want to thank you so much. That was a fantastic presentation. And thank you so much for answering. It was kind of a rapid fire questions that I was throwing at you. Just to remind you, for those of you that are watching, there will be a survey that comes out. And I just want to remind people too, because sometimes people will put a question into their survey. So if you want us to get back to you, just make sure that you include a contact like your email, because the surveys are anonymous. So we don't actually know where it's coming from. And just as a reminder as well, this presentation, as well as Dr. Dalton's slides, will be available on the website probably within a week or so. So you can check back for those. There was someone asking about that. But thank you again. Thank you for everyone attending, and just flagging that. And there we have our slide for our next talk. We're going to have Dr. Tartaglia with us, and she's going to be speaking about, this is another new talk, concussion in women, and that will be 2 weeks from tonight. And yeah, hope to see you there. So thanks again, and have a great evening, everyone.